It's 8 o'clock. At least we're seeing some sunshine today, so that's great. I'm very happy as the Vice Chair for Education today to welcome Dr. Ann Roelke, who will be presenting today. Dr. Roelke completed her Doctor of Occupational Therapy degree in 2022 at Creighton University. She had a specific academic focus on concussion rehabilitation. She has extensive clinical experience as an occupational therapist at UnityPoint Health Meriter, a role she's had since 1993. She provides high-quality, evidence-based evaluation and treatment of adult neuro outpatient services. And a key part of her work at UnityPoint involves developing evidence-based programs in concussion rehabilitation, as well as vision and sleep restoration and neuro-based occupational therapy services. Her expertise in this area is also reflected in her research, including a 2022 publication, Return to Activity, Exploration of Occupational Therapy in Outpatient Adult Concussion Rehabilitation. So Dr. Roelke, we're excited to learn more about your work today and to benefit from your expertise in managing concussions. Thank you for being with us.
Thank you for having me, and thank you everybody for joining me on this beautiful morning. And I am passionate about concussion rehab, and I'm thankful that you're going to be able to join me for this talk about how to identify, educate, and refer. I have no conflicts of interest to disclose. And she touched on most of my nuances of specialties. I did establish the UW Ophthalmology Occupational Therapy Services with Dr. Mandal. And I do driver rehab evaluations and persistent pain. And I did develop 7 courses for an international allied health continued education platform specifically about concussion rehab. So I'm glad you can join me. I'm also a mother of 2 elite soccer players, both who have had concussions. One, our youngest in gym class, our oldest, when he was in elementary school and he fell on the ice, and then a couple soccer injuries. So I know this path as well. And I'm here to tell you that concussion rehab works. It improves patient outcomes, it shortens recovery time, and it reduces societal costs by people returning to work sooner, having less disability and less healthcare costs. So I'm hoping that at the end of today, you'll come away being able to identify the presence of concussion using an operational definition and describe areas of medical management that you'll be able to do in your office. And also be able to educate your patients using evidence-based, publicly available resources. And then to be able to refer to specialized concussion rehab practitioners for this individualized treatment. So something to start us off with. Question: do helmets prevent concussions? Think about that, and we'll come back to that later. In 2023, the American Congress of Rehabilitation Medicine came up with an operational definition for concussion. Different groups have somewhat different definitions, but this is the one I'm going to use. And it's meant to be used across the lifespan from shaken babies to falls in the elderly. It's meant to be used across settings, so including sports, civilian trauma, and military trauma. You know, I've heard it said that, oh, we can't use the military research because those injuries are so much worse. And actually, only less than 17% of concussions occur while deployed, and blast injuries are difficult, but only 17% while deployed. So the military research and resources is really valuable. Also, they put it in print that the word concussion is synonymous with the words mild traumatic brain injury. They are one and the same. So when we consider the operational definition of concussion, there's 6 different criteria. The first being a plausible mechanism of injury, like being hit by or against an object, like a drum falling off the shelf, a suitcase falling off of the airplane bin, or a fall. It can also be the result of an acceleration-deceleration injury, like a motor vehicle accident and whiplash, and also a blast injury. So, when you see them, when they're seen in the emergency department, if they're seen in the emergency department, like, for example, after a fall or motor vehicle accident, you're really looking for those life-threatening, sustaining practices that are most important to look at. And I think because of that, a concussion is oftentimes overlooked. It's anticipated that 50% of concussions go unreported. So we're going to spend a little time with Jane. That top picture, she had a fall on the ice and fractured her wrist. And Jane's doctor recommended that she go to occupational therapy for her wrist fracture and get some work done. And it was her OT that identified the presence of a concussion. But if she had gone into your office and you'd seen her and you identified that she had a concussion, what would you recommend? If the answer is to do nothing, or don't do activities, don't go on screens, don't go out with your friends, don't exercise, don't integrate with the world, don't aggravate your symptoms. If you tell them this, actually, their symptoms will likely be prolonged. The Military and Concussion and Sports Group recommends something different. So the second criteria is clinical signs observed or patient report. So that could be a loss of consciousness, altered mental status, like memory, repeating questions, really being slow to respond or agitated, disoriented, or amnesia or other neurologic signs. So for Jane, she reported being disoriented and slow to respond and sometimes confused. The third criteria is having subjective symptoms plus one or more clinical exam or lab finding. And that could be altered mental status, feeling dazed, confused, physical symptoms like headache, nausea, dizziness, balance, or vision problems, cognitive symptoms like feeling slow or in a fog or difficulty concentrating, or emotional symptoms like being labile or irritable. So for Jane, she had severe headaches and dizziness and felt like she was in a fog. The fourth criteria is having clinical exam or lab findings, and that could be impairments in cognition or balance, ocular motor control, maybe some visual vestibular difficulties, elevated blood biomarkers indicating an intracranial injury. For brief cognitive exam with Jane, when she repeated holidays in reverse order, she was really slow and made errors when she did that. The fifth sign is neuroimaging evidence when it's indicated, but it's not necessarily indicated for concussion. And typically, there's no abnormalities on neuroimaging studies, and Jane did not have any neuroimaging studies. So the issue is, a concussion is a chemical or a physiologic change that doesn't show up on imaging. It's changes in neurotransmitters. A metabolic cascade occurs, blood flow changes, inflammation, maybe micro tears. And symptoms can be present immediately or evolve over hours. And it's typically unusual to have symptoms appear beyond 72 hours after injury. But it's often usual that people have symptoms that are maximized like 3 days, 2 or 3 days after the injury. So the sixth criteria is important, especially for people with persisting symptoms, that the symptoms are not caused by something else. So pre-existing or co-occurring conditions like drug or alcohol or use or medication overuse, co-occurring physical conditions like neck issues, BPPV, peripheral vestibular dysfunction, mental health conditions, and learning or attention difficulties, or headache disorders or sleep disturbances. They oftentimes can have these associated with the concussion, but if they were there ahead of time, it could be, prolongs the symptoms, and it's the concussion is different than this. So of all the people with TBIs, 90% are considered to have mild TBI or concussion. And of that 90% with concussion, 10 to 30% have persisting symptoms lasting beyond 3 to 4 months, according to the Department of Defense. The sports consensus article says persisting symptoms are symptoms that last greater than 1 month. So there's a little discrepancy there. Typically, recovery is less than 2 weeks. And the words persisting symptoms is the current phrase for post-concussion syndrome. So prolonged recovery, who's at risk? Kids, adolescents between the ages of 13 and 17, their brains are changing so quickly that it's not surprising that they take a little longer with recovering. Girls, females, and people with multiple concussions take longer. Also, when there's injury or post-injury factors like delayed removal from sport or delayed access to healthcare, that can cause a prolonged recovery. Symptoms, if they have on-field dizziness, post-traumatic migraines, fogginess, like slowed reactions, impaired memory, they're at risk for a prolonged recovery, as are those with premorbid factors such as mood disorders of anxiety, depression, learning disabilities, ADHD, ADD, and a history of migraines or visual problems or motion sensitivity. So with Jane, she had pre-injury migraines, anxiety and depression, and post-traumatic migraines. But it's important to consider what a concussion is not, and it is not a sports injury. It may occur as a result of a sporting event, but it's a brain injury and should be treated like a brain injury. So the information that I gathered together is from 2 main sources. One, the Consensus in Sports Group, and the other is the Military Health System, Department of Defense. And both of these groups are collaborating now, and they've both updated their protocols in 2023, and their information is consistent with each other. So the Concussion in Sports Group is a group that gathers about every 5-ish years. There's about 30 authors, and it outlines recommendations from the sidelines to long-term consequences. It's written for healthcare providers with fewer resources or specialists, so they want it to be pertinent for people in rural areas or less populated areas. It clearly identifies how much to exacerbate symptoms with pacing those activities. The return to sports stages have been modified a little bit, and we're going to go through just the updates. And it emphasizes the importance of a multidisciplinary teams, especially when people have persisting symptoms. So we're going to do a little experiment. Do helmets prevent concussions? This is our egg experiment. Pretend you have a raw egg in your hand and cover it, hold it really tightly. Don't let anything happen to it. Now shake it. Shake it really hard. Can you prevent the yolk inside the shell from moving? No. Helmets prevent skull fractures. They do not prevent the brain from moving inside the skull and hitting the skull, shearing, possibly rotating in the skull. It can't do that. And so helmets are great for skull fractures, but they don't prevent concussions. So the military health system is the other area besides this concussion in sports where we get a lot of research. And the Department of Defense has different centers of excellence. So the Traumatic Brain Injury Center of Excellence is where I go for this information. And, you know, in the medical world, we are in the Western medicine, non-military civilian world, we're very good at finding resources and research, but we have a harder time finding the military health system specific recommendations because they have their own website. It's confusing. There's a lot of information. But if you search military health system or traumatic brain injury center of excellence, you can come up with this site, and it has just so much information, both provider resources and patient resources. So when Jane comes to your clinic, the focus is to identify a concussion occurred, educate about what to do and what concussion is, and then refer them to specialists who really can work on fine-tuning the rehabilitation. So the first step is to identify. With the sports and concussion group, they recommend the SCAT or the SCOT-6 evaluations, or the child SCAT and SCOT. And these are used, the SCAT is used from the time of concussion to 7 days, and the SCOT is 72 hours and beyond, and the same for the child SCAT and SCOT. The military health system recommends the MACE, and they're similar, but a little bit different. The SCAT goes through neuro red flags, coordination, ocular motor screening, cognition, a symptom questionnaire that's consistent in all of them, and then balance. But the SCOT, the office assessment, that goes beyond. It includes everything from the SCAT, but it also includes a neuroscreen, vital signs, more specific visual vestibular testing, cognitive testing, balance, cervical, mental health, sleep, and exercise tolerance. And that's a lot to get done in your office visit. There's another screen that we do here in our clinic, and I recommend that you do as a symptom questionnaire. It's the Concussion Clinical Profile Screen. It was created by a subgroup of the sports group. It's 29 items, self-report. It's got strong validity and reliability for predicting concussion, and it's more descriptive than previous tools. So the Rivermead has been used for a long time for research, but the Concussion Clinical Profile Screen monitors symptoms over time and helps to identify the treatment priorities. I think you'll see that coming up. They've identified that there's five clinical profiles and then 2 modifiers. So this questionnaire helps identify which clinical profiles they're struggling with most. And that includes cognitive fatigue, anxiety, mood, vestibular, ocular, and headache, migraine. And then in addition to that, the modifiers that impact those profiles are sleep and cervical. So people present with any combination of profiles and modifiers. There's never just one. And this is Jane's profile. She came in and post-traumatic migraine was her main symptom profile, and then anxiety, mood, and vestibular. There are the others, but we kind of identify the top 3. And I think her total score on the clinical, the CP screen was about 57 out of 87. So she was very triggered. And that was from the result of a wrist fracture rather than, something more major. And it was missed by the medical field. So the first thing to do that you can do in your office is really look for those red flags. So that's the sudden onset of focal neurologic signs, such as declining consciousness or cognition, increased confusion or irritability or behavioral change, a new onset of pupillary asymmetry, seizures or repeated vomiting, severe or rapidly worsening headaches, signs and symptoms of cervical spine fracture or cervical ligamentous laxity, weakness or numbness in their arms and legs, and slurred speech or aphasia. When we think about post-traumatic migraines, which was Jane's primary concussion clinical profile, these most commonly resemble tension type or migraine type headaches. But don't be fooled. Medical imaging is different between post-traumatic migraine and migraine. They have clinical features that are similar, but the neuroimaging is different. And this pain is severe. People with a history of migraines will tell you that the post-traumatic migraines are different and much worse than their typical migraines, and like crushing kind of worse. And it's important to have non-medication strategies in their toolkit, but pharmacology, medication is really important with these people. And the medical health system, the military health system, has a handout about medication recommendations and including non-medication strategies. But it talks about limiting abortive medications to avoid medication overuse headaches. So Tylenol, ibuprofen, Excedrin, migraine-specific medications. The best one and least triggering is Tylenol. But it also talks about other medications that may be more effective for this kind of pain. Dr. Gillespie is the UW concussion rehab doctor, and his his preferred choice is amitriptyline. It's his go-to medication for migraine, post-traumatic migraine. And if that doesn't work, then there's other ones like duloxetine or Cymbalta, nortriptyline, propanolol, topiramate, and more. And this handout in the military health system indicates all of those medications for both migraine type and tension type headaches. Another thing to look at is peripheral vestibular disorder. This was Jane's third symptom profile. Her second was anxiety, which often improves with education that we'll get to soon. But vestibular issues were her third clinical profile. And it's present in about 20% of adults with concussions and 33% of children and adolescents with concussions. And what we're looking for is the peripheral vestibular disorder of BPPV, or benign paroxysmal positional vertigo. I have a hard time saying that. BPPV. And there's a 4-item vestibular tool that you could easily use in your office that's valid and specific and reliable for identifying BPPV. So it includes 4 questions. Do you have a feeling that things are spinning or moving around? Does bending over or looking up at the sky make you feel dizzy? Does lying down or turning over in bed make you feel dizzy? And does moving your head quickly from side to side make you feel dizzy? If the answer to these is yes, then it's really important to get them to a vestibular specialist, which is in this area is physical therapy. And they can work on doing some specific maneuvers to get those crystals in their ears back in the right position and resolve the BPPV. You also want to look at their cervical spine using the Canadian C-spine rule. And this identifies situations when radiography is needed, particularly for people over 65 and who have had a dangerous cause of their injury, such as a fall from elevation or high-speed motor vehicle collisions. For Jane, she had mild neck pain and she did not need imaging. Blood pressure is also important to look at because it gives you a window to the autonomic nervous system. And we're really looking for orthostatic hypotension, where we look at blood pressure supine and then standing. And we're looking at positional orthostatic tachycardia syndrome, POTS. And that can also be present after concussion. Sleep is really important to identify. In the general public, 30% of people have insomnia. And after concussion, 50% of people with head injury have concussion or have insomnia. And the gold standard for treatment is the cognitive behavioral therapy for insomnia, CBTI. It's evidence-based, better than medication, and it consists of both sleep restriction or sleep constriction, and it's data-driven. There's few practitioners that practice this, and here at Central Therapy, it's completed by occupational therapy and can be very effective. Some other things to consider in concussion rehab is across the lifespan, adolescence recovery takes longest. And elderly, we want to really look for intracranial bleeds. For people with persisting symptoms, they may develop functional neurologic disorder when the clinical findings are inconsistent. Their brain is having a hard time making sense of the stress in their life and causes neurochemical changes. We're also looking for autonomic dysregulation as a concern when people have persisting symptoms. And then remember that when people have post-traumatic migraine pain, that medication management is typically required, But polypharmacy is also something we want to be concerned at. We want to give them the best bang for their buck as far as medication goes, but not too much. So once you've identified that a concussion is present, we want to educate people about what to do. And typically, it's in 2002, Ponsford et al. Identified that providing early education about common symptoms, recovery time, and coping strategies, though that information significantly reduces stress, anxiety, paranoia, hostility, sleep, and outcomes 3 months after injury. So the sooner they're seen, the quicker they recover. So what education about activity should be given? Most people know the sport's 6 stages of return to sport and guidelines. And for the sport community, it's sport. Return to activity means sport. In military, it means return to duty. And duty is 24/7. So they include more everyday activities and activities outside of work in their recommendations. But they're very consistent. And I'm going to be going through the updates on this. So the first stage is symptom limited activity, or otherwise known as relative rest. And that occurs in the first 2 days, 0 to 48 hours after the injury. It's recommended that on day 2 after the injury, people resume light exercise. Exercise promotes healing. And they progress their activity by keeping their symptoms mild and brief. Mild meaning less than 2 out of 10 increase from baseline, and brief meaning under 1 hour. And that's true for any kind of cognitive activity people do, physical activities, and everyday grocery stores, or everyday activities like going to the grocery store or paying their bills or doing cognitive things. It's not just the physical symptoms that they have. So strict rest, nothingness, cocooning, that can be harmful to people and prolong symptoms. Relative rest promotes healing. So let's take the example. If somebody's watching TV and it doesn't cause symptoms, wonderful. They're fine watching TV. If they watch a movie like Fast and Furious, this may cause symptoms to increase to 4 out of 10 above baseline, and that's not recommended. But if they watch a movie like 27 Dresses, their symptoms may not increase at all, or may increase 1 out of 10 above baseline. So they need to consider the complexity of the tasks that they're doing as they continue doing their activities. So the second stage of the sports and military activity recommendations is aerobic activity, and that's symptom limited activity. And the sports group has separated it out based on the person's heart rate. And you stay in each one of the sport stages for 24 hours. And then if the symptoms worsen, you return to the previous stage that they were at. The third stage is sport-specific exercise or light activity. And the new thing about these stages is that they've identified that continuation above the third stage is not recommended until symptoms and cognition have resolved. And that includes after physical exercise. So they need to be doing well and managing their symptoms at rest with light activity before they go on to more physical exercise or intense activity. There's also guidelines that the CDC came up with for children. And it's things like, there's 19 of them, and it's things like active recovery. Do what you can do, which is another word for relative rest. You want to keep kids engaged in their social activities. You want to get them back to school or adults back to work as soon as possible, but also minimizing their cognitive and physical overexertion. You want to manage their headaches, help them sleep better, and provide cognitive rehab as it's needed. So as we think about kids, we oftentimes think about sports. And there's many risks with sports, and people start asking the question, should my child be involved in or continue playing sports? And this is a great question. Um, but there's also some benefits from being involved with sports. They develop teamwork, dealing with losing, the ethics of hard work, building physical health habits. So the whether somebody stays in sports or not is a really personal and complex decision. And the Concussion and Sports Group recommend that they balance the scientific evidence and its uncertainties with the benefits of participating in sports. And if they're thinking about retiring from sports, you want to include the athlete's preference and their risk tolerance, the psychological readiness to stop, and the patient, clinician, their parent or guardian, and the TBI specialist. And if they do retire, you always want to encourage non or low impact physical activity. So for education, there are some publicly available educational resources that are excellent. The Traumatic Brain Injury Center of Excellence has both patient resources and provider resources, like I said. And in the patient education resources and family resources, they have handouts about all these topics: headache, alcohol, ongoing symptoms, dizziness, visual vestibular problems, sleep, behavior change, memory, neck pain, and back to school. So there's very specific handouts with very specific recommendations, and they're excellent. But people need to get over the idea that the language in it refers to service members and duty and military duty. If they can broaden their mind and expand their definition of return to activity outside of duty and military service, they can apply these recommendations to their own life. The military health system also has a provider resource of a progressive return to activity with very specific recommendations, what you can do as a clinician, about all the different symptom profiles. The Center for Disease Control and Prevention, CDC, also has some excellent handouts, such as recovering from mild TBI or concussion. It shows symptoms that they may experience and then some things to do right away. My favorite handout is their tips to feeling better after mild TBI or concussion. This is a handout that goes through these 4 domains: physical, cognitive, social or emotional, and sleep, and then lists these specific symptoms and very specific, concrete, hands-on recommendations about what to do to help in all of these areas. So it's a wonderful piece of paper that you can go over or hand to a person, and then they have the resources about what to do for all of these areas. Don't forget, you also want to include general medical advice like deep breathing, meditation, mindfulness, putting cold compresses on their head or their neck. That helps to decrease their pain and their autonomic nervous system disruption. They want to eat a healthy diet, which could be a ketogenic or a Mediterranean diet. Omega oils are helpful, vitamin D is helpful, and melatonin. But people also need to be educated that pain does not equal harm. Every day, people have headaches and they have good days and bad days. And there's ups and downs in any kind of recovery. And when they have symptoms, it's normal to have symptoms. It's normal to have an exacerbation in symptoms. And they're not re-injuring their brain because they have pain or because they did too much. It's not causing further brain damage. But that is a concept that is foreign to many people. And so it's important to let them know that exacerbating their symptoms does not hurt their brain further. After you've identified the concussion and you've educated them about what they can do, then you want to refer them to a specialist. At UW, I alluded to the physical medicine and rehabilitation concussion specialist, who's Dr. Gillespie, but he works in this clinic 4 hours a week. And that's not nearly enough to address the number of people that need to see him. And so it's really encouraging it's really encouraged for primary care and other providers to take an active role in concussion rehab and concussion management. Dr. Gillespie will consult with anybody, give medication recommendations or other recommendations. And so you can contact him, and he'll provide as much guidance as he can. But also therapy providers. We in outpatient therapy provide ongoing care and based on individualized plans based on their symptom profiles. So we can help manage their symptoms also. So how soon should you refer to a specialist, to therapy, to other providers? And we know that early care improves recovery. There's multiple studies that show this. Eagle et al. Identified that when seen 8 to 20 days after an injury, there's 10 times greater chance of prolonged recovery compared to those seen under 7 days. And Prattle et al. In 2022 identified that those people who see a healthcare provider after 28 days from their injury recovery is 3 times longer than those seen earlier. So it's important that people see their medical providers early and so that we can begin the process of accurate education and recovery. There's a lot of inaccurate education going on, like don't do anything, stay in a cocoon, and don't do activity. And we need to provide that accurate education to help their recovery start. So where to refer? A lot of people know about UW Sports Medicine, and this is primarily for the athlete to return to their sport. They don't specialize in all the profiles, and especially the persisting symptoms. The UW Neurologic Rehabilitation in Middleton, they do general neuro, which is great. Both programs are great, but we know that people with persisting symptoms need more. So at Meritor, at UnityPoint Health Meritor, our concussion program sees people that have acute injury to chronic persisting symptoms, from kids 8 years old to elderly. And we refer to other specialties as needed, and that includes OT, PT or speech, psychology, a multitude of various eye specialists for different reasons, ENT, and pediatric therapy. So UnityPoint Health Meritor's concussion program, what makes us unique and different, I think, is that OT and PT cross traditional boundaries to provide faster access to help prevent the persisting symptoms. So OT and PT are trained to provide basic treatment in all the clinical profiles and modifiers, even those that are not traditionally in our toolkit. So OT is trained in vestibular and cervical issues, something I hadn't treated very much before this. And PT is trained in cognition, vision, and sleep. And then all of us refer to speech therapy as needed. And the difference between occupational therapy and speech therapy is subtle, and there's overlapping areas that are also addressed by physical therapy and occupational therapy. But we find that after concussion, people are usually able to do their activities, but not efficient or effective in using or doing their activities. They might be able to grocery shop, but as a result, they forget 10 items on their list. Their symptoms are huge afterwards. They crash and they can't do anything for 3 days. And so it's not that they're able, they get back to doing the stuff because they're forced to, but we want to help them do it in a more efficient, effective manner. So in occupational therapy, we address those impairment-based strategies for the symptom profiles, but we also focus on their everyday activities, often higher level activities like scheduling, financial management, medication management, socializing, being in a crowd, cooking, doing project work, computer work, reading. And speech and language pathology focuses on higher level cognitive communication challenges, executive functioning, and they may address some of these same everyday activities, but they're doing it in different ways and for different reasons. So for Jane, she was in therapy, and 7 months after her injury, She was discharged from therapy. She had 5 months of therapy, 12 sessions of OT, 10 sessions of speech, and 8 sessions of physical therapy. And her concussion clinical profile reduced significantly from 56 out of 87 to 8 out of 87 as a total score. And then each of the symptom profiles either significantly reduced or was eliminated at the end of that time. Post-traumatic migraine continued to be her highest, as with anxiety, mood. And then vestibular, she still had some issues, but it was much better than it was initially. So how to refer to UnityPoint Health Central Therapy. If you're a UW physician, you would put in an order for OT, eval and treat, or PT, eval and treat, or speech, eval and treat. And we want to have the diagnosis be concussion, not post-concussion. There's a number of insurances now that are not paying for post-concussion, but the concussion diagnosis is very prevalent and important. And then this is the important thing about sending an order to Meritor. You have to fax it to 608-417-6076. The order does not automatically go to the schedulers. The schedulers can't go into somebody's chart unless a patient calls and says, hey, I was referred to you. Can I get scheduled? So it's important to fax the order to us so that the schedulers can reach out to somebody. And it's important to empower your patient and provide the phone number for that clinic. So 608-417-5050. I don't know how often I have been told personally and have been told that from patients, oh, they're going to call me, and then they don't get a call. So providing both of those phone numbers and faxing the order is really important. If you're a UnityPoint physician, you do an order set of OT, PT, eval, and treat. And then if you want speech and language pathology, you do a separate order for eval and treat with the same diagnosis of concussion. So in summary, we reviewed the operational definition of concussion, and concussion is the same as mild traumatic brain injury. We reviewed what you can do in your practice, which is identify using either the sports or military recommended evaluations, and especially the CP screen for symptom profile and severity monitoring. It helps to identify the breadth of those symptoms. Educate your patient because early education improves outcomes. We reviewed the military health system and CDC clinical and patient resources. We reviewed activity progression guidelines and the role of rest, and provide general medical advice for those symptom profiles. You also want to refer to concussion therapy specialists for symptom management, impairment-based treatments, and return to activity guidelines. So my ask of you is to use the CP screen to identify the breadth of concussion symptoms. You may not know what they are otherwise. Check your patient education material and make sure it's updated with start exercise on day 2, gentle exercise. Do what you can do. Keep symptoms mild and brief, under a 2 out of 10 increase from baseline. And educate people that most people recover in the first month, but some people have persisting symptoms and need additional therapies. I would ask that you also review the military and CDC patient education materials and see if there's a way to include those in your materials that you give patients. And refer to therapy providers specializing in concussion rehab to help provide those improve in patient outcomes, reduce symptoms, and societal costs. So here's a link to your session evaluation. And I wonder if there's any questions.
Well, thank you, Dr. Roelke. That was very instructive, lots of great resources and helpful information. And yeah, there were 2 questions to start out with, and others, please feel free to put questions in the chat. The first question comes from Dr. Barzy. Thanks for sharing this important information. You are often lumping adults and older adults together, but brain structure changes and neurogenesis can be quite different in these 2 groups. Can you share distinctives in managing older adults with concussion compared with other groups, aside from looking for subdurals and neuroimaging? Dr. Barzy is a geriatrician, so thank you, Dr. Barzy, for asking that question.
Yeah, their brain structure is very different, but we work in the realm of function. And so how do these symptoms impact their life? And those symptoms impact people's lives differently at different ages, certainly. Elders, they're probably not worried about work and the meetings and being on screens and computer and the analysis, the extensive analysis that they may have as a younger adult, not, younger than 70. But elders are also very analytical and educated and want to continue. So it's really, more about what do they do in their life and how can I help them continue do that as best as they can with the least amount of symptoms that they can. And the strategies that we employ are specific to those individuals and specific to what they need to do. So if somebody's a factory worker, I'm going to treat that differently than and what they have to endure during the day than if they're a secretary or a CEO. And same if there's a geriatric person, an elder who's involved in auditing 6 classes and on 2 boards and volunteering in the community. I mean, I'm going to try to help them get back to what they're doing. Kids, I'm not a pediatric specialist, but I'm a concussion specialist, and concussion specialists tend to treat across the lifespan because there's not a lot of pediatric concussion programs, but it's not what I do primarily. And so a big part of what I do is educate parents, help them interact with a school, connect with their teachers, find out who their resource is at school, and help to make sure that they're educated about what this kiddo needs and provide breaks and structure within their day. When adolescents get to be in high school, there's a lot of demands, there's a lot of pressure, there's a lot of people, social activities. And so we help to balance those with academic accommodations, physical accommodations, responsibility accommodations, homework. We also do that in the working adult, but those accommodations look different. So it's really based on the functional implications of how their concussion impacts their life and who they are and what they need to do. I hope that answered your question.
Thank you. There's a related question here regarding how to decide who needs more versus who is doing well. The question may relate a little bit to what you presented with Jane. You did a survey for her at the beginning of her treatment at the end. You kind of follow that through treatment as well to ensure that there is improvement, filling out the questionnaire along the way, in other words.
Yeah, we do it at the beginning to identify those profiles. And we have to do a progress note every 3 months or 10 visits. And so we at least do it at that time. But as they progress, we are going to do it. We're not going to do it every week. That would get a little old for all of us. But we do it when there's significant change or at the time of a progress note. And usually it's really encouraging to see that change or to see that things aren't changing that much. And what do we need to do differently, either in their therapy or their everyday activity? And in occupational therapy, we also do another tool. It's a subjective tool, Canadian Occupational Performance Measure with a COPM with very good validity and reliability, where people identify their goals and then rate their ability and their satisfaction. And that looks at their functional skills and what's the challenge and what's changing over time versus the symptom questionnaire. The CP screen looks at their symptom change over time. So I think it's important to look at their symptom, and that may reduce, it may reduce significantly, it may not reduce a lot, but their COPM on how their function is changing typically changes significantly. And so we in occupational therapy will do both of them hand in hand to guide us what we're going to do. Typically we see people once or twice a week, and then over time we see them with less frequency. Somebody who's going to recover quickly, I mean, it's not uncommon for us to see somebody for maybe 3 months, and then they get better. But it's also not uncommon to see somebody for a year who has multiple pre-injury comorbidities and psychosocial stressors and functional neurologic disorder and all sorts of other areas. So we're going to be evaluating and doing this CP screen, at various times for both of those different groups.
Yeah, thank you. Oh, go ahead.
Can I say one more thing about
Of
that?
course.
With the CP screen, we're not looking for a score of 0. The first question on the questionnaire is, do you have feelings of sadness? Well, everybody has feelings of sadness. Everybody has things that come and go during the day. They might have a sleepless night. So it's not that 0 is the score that they get to. It's reducing that score as much as possible and improving that COPM or their functional ability as much as possible.
All right, thank you, because it kind of relates to, we have many patients who are sedentary patients, and you're talking a lot about military and sports, but we also have another group of patients who don't do much, and how do we assess their improvement? But you've kind of explained that to some extent there for sure.
Yeah, let me clarify. Our expertise here is not military and it's not sport. So those are the two research bodies of evidence that inform our practice. But we see adults, everyday adults. We see housewives and mechanics and grandmas and grandpas and teenagers. And so I mean, a passion of mine is to let people know that concussion is much more than military, and especially much more than sport. So thank you for pointing that out. We do the same thing for those sedentary adults. We get them moving because we know movement decreases anxiety and depression. We know movement increases blood flow and takes away the bad chemicals and brings the good ones. It promotes healing. It's about engaging in their environment. And sometimes people have pre-injury issues that we deal with after concussion. For example, sleep. I said that 30% of the general public have insomnia issues. But then once you have a concussion, they're worse. So if they had pre-injury insomnia, I'm still going to work to help improve that insomnia because I have this opportunity, and by chance they happen to be referred to me, so I can help benefit them in that area. So we're looking at any areas that we can be impactful with to help them get back to their life.
All right, thank you. There's one more question, but first I want to ask a question about patients who have multiple concussions. And what I'm asking about is, do you find that patients have similar symptoms with less and less head trauma as they go through more and more concussions? I have a patient who has had multiple concussions, and it seems like very minor head bumps, then her symptoms come back regularly. And I'm curious if that's something that you see as well. Multiple concussion symptoms come back more quickly or strongly.
So the thing with multiple concussions is they seem to be cumulative. So the first concussion might go away in 2 weeks. The second concussion might take 3 months. The third concussion might take 9 months. And so it's nice to know how long did your last concussion recover by? And that can kind of give you a guide for how long this one might stick around. And there's also something that we notice. We notice the same thing. So minor head bumps and their symptoms come back. Those are not necessarily considered new concussions, but they're flare-ups of their concussion symptoms. And so it's nice to educate the patient that way. That's what Dr. Gillespie talks about, because we also want to decrease the anxiety that people have about these symptoms that come back again. I mean, they might need to go very slow. I teach people to not hit their head. When they're going down to pick up a piece of paper off the floor, they might need to be taught to hold on to the table so that they know where that table is, so that when they come up, they're not going to hit their head on it. Same thing with a freezer, an overhead freezer or a refrigerator. People bump their heads all the time, and that can flare up their symptoms, but it's not necessarily a new concussion. And they would probably, with those new symptoms, have to backpedal with how much they're doing, but hopefully they're educated in how much to exacerbate their symptoms and how to back off on what they're doing so that they can recover a little bit more and then get back to it. But those people that have those flare-ups are probably having a prolonged symptoms and probably dealing with lots of things in their life. And so educating them about the impact of all these areas to help them manage with those flare-ups when they come.
All right, thank you very much. A question about it would be helpful to build the therapy's information into our rehab orders. Thoughts on building a concussion pathway in HealthLink. That could be very helpful. What is your thought?
I have a couple thoughts. Yes, it would be helpful for doing that. I don't know how to do that. There's and UW HealthLink, is that separate than UnityPoint HealthLink? And there's, time, energy, and resources, which is time and access, and we don't have a lot of time to build those kinds of resources. Patient care and access is the dominating factor. Yes, it would be great to build that, but as a clinician, I don't think I'm allowed to have time to do that. So if you know anybody who's interested in that or know how that happens, I'd like to be a proponent of that. And email me. My email address is Maryann, MARYANN .ROELKE @unitypoint.org. Again, that's Maryann.ROELKE @unitypoint.org. And, I would love to see that happen. I'm just not sure of how or who does that.
Yeah, good question. It's a tough one to answer, but thank you for being willing to collaborate. And then we have a question about the relationship between concussion treatment and CTE. Thinking about the practice of putting football players back into the game after hard tackles or loss of consciousness on the field. What do you know about that connection?
The connection between concussion and CTE?
Yeah.
We know that there is a connection. We know that CTE can only be diagnosed after the fact, after they're dead and by autopsy. They have identified a new title, a new name for a condition to try to link those, and I'm forgetting what it is. And that is not good of me. And if you email me, I will tell you what that is. But they're trying to make a more direct connection to identify who might be developing the CTE. And right now, all we have to go on is their symptom severity and trying to be cognizant of their practice, their play, you have to consider, when do you end? And oftentimes I like to think about symptoms, and how severe those symptoms are. You want to catch it early, if you have 3 concussions and the symptoms are really bad, you might think about stopping your sport. And those professional, in the sports consensus article, they do talk about long-term consequences of concussion, and they talk about CTE, and that's where they have the diagnosis title for when people are alive. And the people that are most at risk are those professional athletes to getting CTE. The amateur athlete is not as at risk. I always tend to take some of those sports research with a grain of salt, because I was around before the NFL determined that there was a link between concussion and CTE. And before that, about 2009, they said, no, there's no connection. And then they finally admitted that, yes, there is a connection. So I'm a little wary about research from the sports groups saying there's not connections. But I do know that they're being more transparent about what those connections are. And the sports and concussion consensus article does talk about the connection between mental health issues, cognitive issues, progressive dementia, neurologic degenerative disorders and CTE. So I would send you to that article for the specifics.
All right, Dr. Roelke, thank you so much for this wonderful information. Great presentation. Very helpful for all of us to hear more from you, and you'll probably see more of our patients. So
Great.